Good morning, good afternoon, good evening, depending on where you are. Welcome to the PHC webinar series at IPHC. As you know, most of you know, the International Institute for Primary Healthcare is established by the Ethiopian Ministry of Health back in 2016. The institute envisions to become a center of excellence in primary healthcare. We are also working to become a WHO collaborating center for primary healthcare in Ethiopia and in Africa. As we are in the UHC's celebration week, and we are very happy to organize this important webinar with great speakers. Before I proceed, allow me to say a few things about the International Institute for Primary Healthcare. We have been organizing several webinars on important topics, particularly on PHC, and we strongly believe primary healthcare is a means for the attainment of universal health coverage. Countries are required and needed to reorient to primary healthcare in strengthening their health systems, particularly. We have witnessed in Ethiopia how primary healthcare is able to enhance access to the vast majority of the population. And we have been doing different capacity building nationally, leadership and governance, testing innovations, and also sharing experiences among countries in Africa and beyond. This is part of the Global Primary Healthcare Strategic Team and the Advocacy Team who organized this webinar on this important topic. We have great speakers, Prof. Henry Perry and Mr. Wandasan Asnaka, whom our moderator, Prof. Getinat, will introduce shortly. But allow me to introduce to you the moderator for today's webinar on this important topic entitled Pathways to Universal Health Coverage, Understanding the Players and Their Impact. Prof. Getinat would be moderating the session. Prof. Getinat is a medical doctor and holds MPH and PhD in public health. He is a senior researcher at IPHC with extensive experience in health research, teaching, and consultancy services. He holds a honorary adjunct professor position at Bahar Dar University. He leads the implementation research section of the knowledge generation and management team at the Institute. And the objective include enhancing the capacity for implementation research for informing policy and program improvement. His work focuses on identification of implementation gap, documentation of programs, generation of evidence synthesis, sharing the evidence to inform the primary healthcare systems. He disseminates evidence through publications such as issue briefs and policy briefs, peer-reviewed articles and books. He also co-authored the HIP of Evolution book, which was published by the Institute in collaboration with the Johns Hopkins University. He collaborates with the Ministry of Health, NGOs, national universities, and global partners in the research institution. We are happy to have you, Prof. Over to you. I hope we will have a great deliberation and discussion. And as usual, would be another very important webinar series that will be organized by the Institute. Over to you, Prof.
Thank you very much, Dr. Antana, for your generous introduction. I would say really welcome to this exciting seminar, and good morning, good afternoon, and good evening for some of you who are attending this webinar all over the world. This topic is, as you know, a very hot topic and also exciting because we are celebrating it this week as well. So we have very distinguished presenters today, both of them, and they'll look at it from different perspectives, and looking at their CV, I think you will enjoy their presentations, and also hopefully you'll have so many questions so that you can harness from their experience. So today, regarding pathways to universal health, one of the presenters is Professor Henry Perry. Probably some of you or most of you know him. He's a very well-known person. He works as a senior associate in the Department of International Health at Johns Hopkins University, Bloomberg School of Public Health. He's widely known. He's also a champion of community-based primary healthcare, particularly. His contributions are in those areas. Since his first medical practice in Bolivia in 1980s, for the last 5 decades, he has been working in this area. So his publications on community health and community health workers have been widely cited. Actually, we can say also have been used as evidence-based inputs as well as advocacy inputs at global level. He has really a growing recognition of the importance. He has contributed to the growing recognition of the importance of strong community-based primary health care programs in general. He has over 250 publications, peer-reviewed books, chapters of books, and some of you might have read his peer-reviewed books or peer-reviewed books or articles or review, whatever he has produced, including reports or anything related to that. For instance, in 2020, Health for the People, National Community Health Programs from Afghanistan to Zimbabwe. In 2021, Journal Supplement, Community Health Workers are Dawn of a New Era. And the 2023 Journal Supplement, Reducing Inequalities in Maternal and Child Health in Rural Guatemala through CBIO and Plus Approach. His publications have been really cited more than 9,000 times. So his publications are widely cited and has been recognized really as the most cited publications in the last 1 decade, and has been recognized by Clarivate for authoring multiple highly cited papers, which ranked in the top 1% of publications. Also, an interesting course he's giving is his massive open online course, Health for All Through Primary Health Care, and has more than 90,000 attendees since he started the course. So Professor Perry is an MD, and also he has a PhD degree, also an MPH degree, all obtained from the Johns Hopkins University. And actually, it's a privilege to introduce him. And Professor Perry, now really the time is yours. Over to you. Thank you.
Thank you, Getnet. Good morning, good day, good evening to everyone. It's a great privilege to be here with you today. I'm going to share my screen with you, so I hope that this is appearing. Can you see that?
Yes.
Yes.
Good. So I entitled my presentation as The Quest. Universal health care, universal health coverage is a step along the way to leading to HFA, that's Health for All. As we think about where we are today, I think it's important to take a moment to step back in history a bit and realize that it's been 75 years now since the United Nations shared with the world its Universal Declaration of Human Rights. And in that declaration, it stated the following: everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing, and medical care and necessary social services. And also it said that motherhood and childhood are entitled to special care and assistance. Now, here we are a few years later, in which in 1978, we had the seminal International Conference on Primary Healthcare at Almaty, Kazakhstan, at which time this wonderful Declaration of Almaty was released and continues to guide and inspire us as we continue on this quest towards health for all. And that declaration said that an acceptable level of health for all the people of the world by the year 2000 can be attained through a fuller and better use of the world's resources. Here we are in the year 2024, and we have so far to go. The United Nations tells us that only half of the world has access to a complete package of basic and essential primary health care services. And even in the past decade, the progress has been minimal towards achieving this goal. And I'm of the firm belief that part of the reason that we're not making the progress that we should be making is we haven't invested in what I call the primary healthcare community platform. That is, the services that take place outside of primary healthcare centers that reach out into the community. And in my view, the investments in this portion of our health system are way behind what they should be. And I like to say that the community platform is still by and large an underfunded afterthought. The potential of it has still to be realized. And there is a growing awareness of the need for a stronger primary healthcare community platform. Some of you may have heard of the Community Health Delivery Partnership, which has emerged within the last year or so, which is the collaboration of all the major entities in the global health world to bring focus to the need for strengthening the services that can take place out of the community, and particularly the services that community health workers themselves can provide. I've had the great privilege over the past year or so of working with UNICEF and other partners towards thinking about a next generation primary health care community platform. And we've put a lot of time into thinking about what such a platform might look like. And not only thinking about it, but costing it and then calculating what the return on investment might be if we had such a platform. And the Ethiopian experience has played an important part in our thinking on this. And here you can see a health post in Ethiopia, along with some of the health extension workers at various health posts. And there are a number of elements of the Ethiopian primary healthcare community platform that have influenced our model. But one of them is the idea of having every household included in the system and having a way to reach every household in that system on a regular basis. And you can see here in the photograph at the bottom in the center, one of the features of the Ethiopian community-based platform that I like a lot, and that is the family health folder. You see these two health extension workers with their family health folders that are linked to every household, and every household has been numbered, and the health extension workers have a way to reach out to every household, which is part of our model, as I'll explain in a minute. So after extensive discussions with many different people with a lot of experience, we've devised this generic community health worker model, which could be used as an idea, as a beginning point for countries to think about how to strengthen their own primary healthcare community platform. And what we have here is a health post that serves 4,000 people. In Ethiopia, the health post serves 5,000 people. Here we have a health post serving 4,000 people. And in the Ethiopian case, we have 2 full-time health extension workers. In our model, we've got 4 full-time we call them community health workers here. And in addition to these 4 full-time community health workers, they would be working with a series of part-time community health workers. And you can see how this is set up here. And it's also built around the health extension model in Ethiopia in the sense that we envision that there would be one full-time community health worker based at the health post, but the rest of the time, the other 3 would be out in the community supporting the part-time community health workers. So for a population of 4,000 people, we'd have, as I said, 4 full-time workers, and they would be making, we estimate, $185 a month. And then a male-female pair of community health workers would each be working with 16 part-time community health workers who would be working 15 hours a week. And the part-time community health workers would be making $40 a month, working 15 hours a week. And the part-time community health workers would visit every home every month. And each part-time community health worker would have 25 households under his or her responsibility. So in a population of 100,000 people, we'd have 25 health posts, 100 full-time community health workers, and 800 part-time community health workers. So we've done the math and have worked out what the cost of this would be, being relatively generous in terms of calculating the various expenses. And according to our calculation, this would cost $21.58 per person per year. That's over the whole population. And this has been set up to be a 20-year program, and there would be 10 years of scaling up and then 10 years of full-time operation. We have estimated what we think the return on investment would be in terms of lives saved, in terms of savings to the health system by having health services readily available close by, earlier treatment, and less severe hospitalization. Surveillance is also built into this, so detection of disease outbreaks would become very feasible with a paid worker visiting every home on a monthly basis. And so we built into this some estimated savings from reduction in the risk of a pandemic, which has, as we all know, a horrific economic cost to it. And then there are also economic benefits that arise by giving community health workers a salary. And so when you add all this up, the benefits from a program like this would reap $10 for every dollar that's been invested in this system. And of course, you can see here that we're envisioning a broad role for community health workers that go far beyond what has typically been the case in the past with the focus on maternal and child health, moving into non-communicable diseases, diabetes and hypertension, moving into HIV and TB, and other very practical things that we would expect from a primary healthcare system. One of the interesting things that I learned from all this is that providing eyeglasses to elderly people who have near vision impairment, presbyopia, can greatly improve the productivity of older people and enable them to generate more money. So we've built a benefit in here for that. And you can see the other things that are a part of this that have an economic return that have factored into our return on investment analysis. We've also estimated that this model, if it were implemented, And this model, I should say, is specifically built for low-income countries and lower middle-income countries, which is about a third of the world's population. And if this program were fully implemented, in our estimate, it would save 56 million lives over the next 20 years. So I'm a strong believer that this type of approach is feasible, it's affordable, it's cost-effective, and it is the best way that we can move towards universal health coverage in the near term and help us to reach health for all sooner rather than later. And I hope that we can all continue to push, as the International Institute for Primary Healthcare is doing, towards stronger primary healthcare programs, and in particular towards community outreach, in which we have well-trained and adequately paid workers who can do a broad variety of things in a way that's feasible for them and doesn't overtax them and overburden them, which I think is a part of our model. So I'll close with that and hope that we can discuss some of these issues as we move forward in the discussion. Thank you very much.
Thank you very much, Professor Henry. An exciting presentation, and also really it was very well presented, and you have given us really some important landmarks, including starting from the declaration to like the Almata Declaration 1978, where primary health care was declared, and the human rights in 1948. And generally, for the last 45, now about nearly 50 years, so we can say that, as you said, primary health care is underfunded. That is a very important point, and probably we'll have, more questions and discussions how we can overcome that. There will be questions and probably comments and discussions around that. And then also the generic community health platform that you presented, along with other programs like the Ethiopian Health Extension or Primary Health Care Program. Thank you very much. So now we'll go directly to the next presentation. I will introduce the next presenter, and then you can keep on, putting your questions on the QA question, and then on the chat, and then we will read these questions, and they will respond to those questions. Now I will introduce Mr. Wendosen, a highly distinguished person also, working at UNEP, UN Environment Program based at Geneva, particularly on policy and partnership as a coordinator of the UN Environment Program. He's responsible for development and implementation of wide range of partnership activities in the areas of environmental sustainability, governance, health, education, and public health public participation with partners including governments, sister UN agencies, private sector, civil society, academic institutions, and you can see the range of partnerships he's coordinating, which is very important for primary health care. And also he leads the UNEP's engagement in regional ministerial processes and interagency mechanisms, including environment and health, regional Regional Forum for Sustainable Development, Education for Sustainable Development, One Health, and facilitates the participation of governments, major groups, and stakeholders in the work of UN Environment Assembly through regional and sub-regional consultations and program delivery. He actively contributes to the implementation of the 2030 Agenda, while promoting the role and positioning UN environment on SDGs, which is critical, as you know, at regional, sub-regional, and also national levels, including having substantive inputs to the work of the UN Sustainable Development Group for Europe and Central Asia, and its issue-based coalition, and Geneva-based UN and other intergovernmental processes, and promoting integrated approach for environmental sustainability at all levels. He has a very nice combination, educational background in development, in economics, and also in public health. Thank you very much. And the floor is yours, Mr. Rondosen.
Thank you very much. I hope you can hear me loud and clear.
Yes.
Excellent. Thank you for that introduction. And most of all, thank you for the International Institute for Primary Healthcare for inviting me to speak and on this important day, the day before the UHC Day. I'll be focusing on the one I know you work a lot on, the primary health care, which is addressing health needs at the source. We also talking about addressing or preventing emergencies like the ones we have experienced through COVID. How can we also prevent them at the source? And that is maybe an area of work I would like to speak about. The professor before me talked about the social and economic impact of COVID. I think we've all witnessed it in our families, in our communities. And I think one of the things we're trying to do with a range of organizations, in particular with the FAO, WHO, the World Animal Health Organization, and UNEP, is exactly that. How do we make sure that we are better prepared in terms of preventing the next pandemic, and especially from our side in the context of environment. Today, almost 70% of the emerging infectious diseases are very much linked to animals, wildlife, and that's why we need to focus a little bit more in preventing it at the source. So the One Health approach, I think many of you're very familiar with that. It's an old approach. It is about integrated approach. How do we respond to crisis in an integrated manner? So for that, as I say, these 4 organizations have come together especially after COVID. How can we respond better? And based on that, we've put together what is called the One Health Joint Plan of Action by the quadripartite that is looking at 6 specific areas. And one, of course, one area in the context of the capacity, strengthening the capacity of the health system to respond to this kind of needs. How do we reduce zoonotic epidemics and pandemics? How do we deal with neglected tropical and vector-borne diseases? How do we strengthen food safety risks? And how do we also curb what is now called the silent pandemic, which is not silent, it's killing, over 5 million people a year, this antimicrobial resistance, whether it is to do with the overuse or misuse of antibiotics on one part of the world. And the other part of the world, we don't even have enough antibiotics to deal with current crisis. So this is something also UNEP extensively worked on, looking at the environmental dimension of AMR and how we can actually improve by working with the agriculture sector, the pharmaceutical sector, the chemicals industry, to make sure that this kind of antimicrobial genes are not introduced into nature with a significant impacts in terms of water, soil health, and so on. So maybe where I want to focus is out of the 6 tracks is the one number 6 is that is focusing on how do we better integrate the environment into the One Health approach. So we've looked at 3 specific pathways, where we're starting with whether or not we have the policies, legislations in terms of advancing this. Second one is looking at organizational development. It also looks into implementation and sectoral integration of, whether it is the animal, human, or environment interface. And the third one is whether or not we do have, better data evidence to make policies, but also the actions that are needed. Why we should do this? Why are we integrating environment? Of course, now we're increasingly seeing the interrelationship, the interconnectedness between humans, animals, and environment, and it is direct impact. And when I say direct impact, it's in terms of negative impact and its consequences. And because of that, there's a need for this agencies. This also, by the way, applies at the national level with all the ministries, whether it is health, agriculture, water resource. There's a need to speak with one voice and a harmonized approach in terms of addressing this kind of emerging pandemics or epidemics. So within the main objective is basically, the areas of actions that we are taking is looking at how do we protect, restore, and prevent? How do we mainstream environment into the One Health approach? How do we integrate? There's a vast reservoir of knowledge that actually exists in terms of environment, but how best can that be also integrated into the health sector and others? And also creating that interoperable in-service training program for both, we in the environment, we're very good at the environment sustainability agenda. And you in the health sector, you are very, very good at your own sector. But then we need to have that interoperable programs to address this kind of emerging infectious diseases. So the track has a specific areas of focus. What we're trying to achieve is, okay, how do we make sure that we create better understanding of the health threats caused by unhealthy environment? As I said, how do we strengthen partnership, but also how do we make sure that we do have existing policies, legislation, practices? How do we actually implement them? And as a UNEP, we're a custodian of quite a number of multilateral environment agreements ranging from climate, biodiversity, chemicals, waste, and pollution. But until they are implemented, until they are put into place, it is still a challenge. They always remain a policy on paper. So part of that work is how do we make sure that they are actually implemented at the national level. Mainstreaming, the health of the environment and ecosystem into One Health is another priority. Particularly in terms of environmental knowledge, data, and risk factors, they need to be better integrated into in One Health. Again, in terms of environment sector source data evidence into the decision making process, it's not just only about policies, but how do we make sure that they also form an integral part of the decision making process, and that way we can actually mitigate, the health threats if they are fully integrated. And the same, I'm just breaking it down into what I said in the context of the training programs that are needed is, let's not be sector specific in our own, but how do we make sure that, people in the medical field, in agriculture, in the veterinary field, they are the knowledge and data and the evidence that is actually that exists, you can make it interoperable, but at the same time it is widely shared. the pathway for, particularly when it comes to governance, policy, and legislation, is one, in the context of the governances, the environment sector and actors being at the table. I mean, this is also something we're missing in the and when we talk about primary healthcare, how do we make sure that even the environment sector people and actors are also part and parcel of addressing health needs at the source? So you need to have an environment sector also sitting there. And I've mentioned a range of multilateral environment agreements that we have. And these agreements are basically designed to promote cooperation, but at the same time to address some of the challenges that we have. Advocacy, I mean, it's good we have the science, it's good we have the data. As long as they are kept, in our own sector, it doesn't benefit that much. So how do we make sure that this is also spread across different sectors, and those co-benefits are actually shared with a wide range of entities? Financing, absolutely. It's a big problem in terms of implementation, but at the same time, there are also quite a number of opportunities. We just have to be better prepared, smart in terms of attracting the financial resources. So this is basically the angle on governance policy. The second one is on operational part. Maybe I would need to go a little bit faster. The key behind this is to make sure that One Health implementation around national level projects and programs and activities. This is where the focus is, in particular organizational institutional development, ability to implement, but also the sectoral integration that is needed. The third one, in terms of data, I've said it a little bit. How do we widely? One is data in many places is also the missing element. Today, much of the decisions we are making is based on missing data. That's why we're having quite a lot of problems. We design policies with the missing data, and then also we implement projects or activities with the missing data. So that investment is so important in terms of data and evidence. Building that information system, particularly the early warning system. I know Ethiopia is one of the recipient of from the pandemic fund. One area that is actually looking at is this surveillance capacity in terms of early warning and system. This is something that we really need to build, and this is also an area that we are working on. So knowledge exchange, it goes without saying. This is about sharing the evidence that is available. So some tools that we have worked on, which is quite useful to you also, is we're not only having the joint plan of action with 6 tracks. We also have a guidance in terms of how to implement this at the country level. I won't speak a lot on this one, but I will share my presentation so that people can go through it. And it has 5 specific steps. And in terms of one by one, how you could do it at the country level. We also launched recently a more specific one targeting UN country teams. And I think in Ethiopia, we have one of the largest UN country teams in the world, actually. How that the UN country team can also roll out the joint plan of action at the country level. And this document is also available, and then it cuts across several of the SDGs, the Sustainable Development Goals beyond SDG 3 on health. So this guidance, we launched it last year at the Climate COP in Dubai, and I urge you to have a look at it. It's available on our website, but as I said, I'll be sharing my slides, so that way you have a bit of time to go over. So this is just a description of what it looks like, so I will not go into. Now, in the context of course, resources, as I said, are quite needed in terms of implementing One Health approach, whether it is at the global, regional, or country level. For example, of course, the pandemic fund, I just gave this example. This is something we've succeeded with WHO, FAO, UNEP, and WOHA in our region, is specifically on the three components of the three criteria of the pandemic fund on surveillance, early warning, lab systems, human resource, particularly the need for workforce strengthening, even in the primary healthcare. We also need to invest a lot more in terms of the workforce that is needed to advance the One Health agenda. These are some other areas where we're very much involved in UNEP in terms of advancing the One Health approach, and in particular, this is a work we do with the WHO regional office here, and also the European office in Copenhagen, particularly looking at integrating nature, biodiversity, and health. This has become an important component in our biodiversity work, and it should be the same for Ethiopia or other countries. Many countries are also currently presenting what is called the nationally determined contribution in terms of climate change. That also has a big component in terms of health, and how health is impacting, or how climate change is actually impacting health. I mentioned environmental dimension of AMR. This is a big issue for us in UNEP, but I mean, including for the rest of the world, and that's also an area that we are focusing on. So we also have other tools in the context of a common approach within the UN family, is in terms of a common approach to biodiversity, but also a common approach to addressing pollution. Why I'm mentioning them is they have significant impact in terms of health and well-being. Chemicals exposure or pollution by itself has a huge impact in terms of our health, whether it is air pollution or water contamination or soil contamination. That has a big impact, and that also comes to in the context of the health impact of whether it is children or adults. So that's why we need to have a common approach in that. Maybe something of publicity, also maybe a request for all of you, is we're currently at UNEP, we're leading a program called Nature for Health. It is really looking at how do we ensure that we're preventing pandemics, as I said before, they're starting. And this is more specifically strengthening the environmental aspect of One Health at the country level. So we will be launching a call for proposal in the coming weeks, and it's a $2.2 million per country in terms of integrating the environment into One Health. I think this is an area maybe you could look at, and if you're interested to apply, all the relevant documents are available, or I'll be happy also to share them. If you go on our website, this is probably the first thing that is available. Specifically, how do we make sure that we preventing the next pandemic from happening? In particular, what I said in the context of if the evidence shows 70% of the emerging infectious disease is actually originating from animals, wildlife, and I think we have to seriously look into that. And this is an area where we're trying to address through the Nature for Health initiative. I think I would stop here. I hope I didn't chew into your time. Over to you.
Thank you very much, Mr. Wondersan Kubrat. A very important, he has raised very important points in his presentation. I think there are questions in the QA section. He has stressed, as you have seen his presentation, the One Health approach and the environment as an important component, including like focusing on capacity of health systems, epidemics, food safety, the silent pandemic also he mentioned, usually forgotten, but there are some initiatives, but not really widely addressed, the AMR issue. And then also, how do we translate this? How do we really, what are the key areas to the pathways and to address these areas, including usually as barriers, but if we address them very well, we can harness effectiveness in this regard, like including, the government, the policies, the legislation, financing issues, and advocacy, the importance of advocacy. And the second, as institutional and organizational reforms or development, including implementation, integration among, or the one we call intersectoral collaboration, and use of data or evidence to inform systems or the information system in general. So these are some of the areas. I wouldn't try to really summarize what he presented, but just to highlight some of the most important areas for our discussion. So thank you very much. Now we can go to the question and answer session. And if you have seen the box, there are questions there. Professor Henry, do you want to? There are important questions raised there. Yeah,
I look at them.
Yeah.
That if you could read them, if you could read them to me, then I'll try to respond. So just sort of go down and go through the list, and I'll be happy to do what I can.
Yeah. Okay. Thank you very much. That's easier. Yeah. One is by Yisfalem, who is asking, who are the P community health workers? Is the cost for part-time community health workers included in the cost? If so, how can we pay? That's one of the questions.
Yeah, so the part-time community health workers are paid. In our model that we calculated, they would make $40 a month for 15 hours worth of work. The full-time community health workers would be paid $187 a month. And so the part-time workers would receive an equivalent amount based on the number of hours they worked. We assume for our model, of course, this is for a third of the world's population. So, every country would have its own variation of this, but we had to start somewhere and had to simplify in order to create a model like this. We assume that the financing of this would come from government. We don't specify further where that money would come from. Of course, it could come, some of it can come from international donors for the very poorest countries, but we think that except for the very poorest countries, all of the countries otherwise should be able to pay for this themselves. We model this as 10 years of scaling this up, so there's plenty of time to adjust as the cost increase each year. And we think that this is readily affordable for almost all countries except for the very poorest countries. And we know that there will be need for international assistance and donor support for the poorest countries until they have the capacity to finance this on their own. We don't get into this in our report, but it's going to be obvious that there's going to need to be some redistribution of the way governments spend their money on healthcare more broadly. And it's so easy based on political influences. It works at the national level for very well-connected, politically influential actors, both in the health system and beyond it, to push for high-powered, expensive technology and tertiary care centers. And so we have to counteract that and push very hard for the value of investing at the bottom of the health system. And this is a political problem that we all recognize is there, and we all need to work together to push decision makers to be aware of how important funding this bottom level of the health system is.
Thank you very much. There is another question, maybe later on, Mr. Wenderson also can add to that, because we are thinking community health programs also outside health, so including health and outside intersectoral. So how could this community health model be financed, especially in developing countries? That's the other question asked by Davy.
Yeah, so let me expand on that. It's widely recognized now that these systems have to be developed and financed by the governments with their own resources. And there's no reason why governments cannot do this. We're not talking about a lot of money here. And so if the proper forces are brought to bear, then the governments will be able to finance this themselves. But there has to be a powerful political argument for why this is the case, and our return on investment analysis is one part of that. But the benefits for people to have a health worker visiting their home every month who have a broad variety of skills to address problems that not only return an investment in dollar terms, but also meet needs of people, is a very powerful message. And so somehow we need to make a stronger case for why we need to do this. And I know the Financing Alliance for Health is pushing for this, and increasingly all of the major players in global health from the government side and the UN and the World Bank and the leading countries of the world are recognizing the need to promote this idea. But at the end of the day, it's the countries themselves who will have to finance this, because it's a long-term part of the health system that donors are not going to be able to contribute to in the longer term, of course.
Thank you. There is another question also by Thomas Ganayo to Professor Henry. Does the ROI, probably I forgot what it means, include health posts?
Yes.
The 1 to 10 ROI is almost equal to previous research on community health workers' investments without considering health posts. I would appreciate it if you explained it further.
Yeah, our return on investment does include the cost of building and operating the health post, and we have money built into it for drugs and supplies and so forth. Although these are not easy to estimate, we have included what we consider to be a generous amount of money to provide supplies and medicines at the health post. And of course, the community health workers out in the community would also be providing various supplies and medicines as well.
There is another question by Adisu for both of you. Mr. Wenderson can add to that later on. I would like to hear more on leveraging technology in strengthening the primary healthcare services in LMIC, where their funds are significantly a limiting factor. This is by Adisu.
Yeah. So I think there's widespread agreement that technology is going to play an increasingly important role in building the capacity of community health workers at the local level to provide services through communication with higher levels in the system, through having tools that can enable them to provide better care. Registration of vital events is one small example. The technology that would enable community health workers to formally register births and deaths and have that put into the national vital events registration system. These things, and also diagnostics that community health workers can use at the home for detecting illnesses, HIV, malaria, on and on. These things will play a very important role moving forward in the next generation of community health workers. And nobody knows the details of how this is all going to work out. But I think it's clear that this will be an important part of community health workers' activities, and it'll benefit the services at the household level out in the community, no question about it.
Thank you. Another question is from Shambal, who is saying, we know that universal health coverage need constructing health facilities to access health service for all in a short distance, which needs huge finance. Keeping quality of service is another. Health service tip, which needs another huge finance. How do we balance these?
So my answer to that is that, of course, we need health facilities. We need hospitals. We need primary healthcare centers where we have doctors and nurses and higher levels of care. We need those, but those are expensive. They take a long time to build. They take a long time to fill with the appropriate staff. And so we need those, but we can't wait until those are functioning. And the model that we're proposing can be implemented very quickly at a much lower cost in a way that would be very effective in improving the health of the population. And so my position is that governments need to give priority in expanding their investments in healthcare in the community platform. And that investment needs to grow at a faster pace than investments in building facilities and higher level care. We need to measure this. Unfortunately, it's very difficult to do, but we need to have metrics that show our people that our governments are really using their resources in a way that's going to benefit them. And unless we can really show that governments are pouring their investments at a faster rate at this lower level of work, we won't have that kind of assurance that our government is using its resources wisely.
Thank you very much, Professor Henry. We'll come back to you. Now, there are other questions to Mr. Mengistu. One question you can add to that as well. Okay, this probably from Dr. Mengistu Asnaker, who is my colleague and a friend. Thanks, my brother, for the usual great presentation. Looking health from the side of the other sectors. In times of a number of global crises, COVID-19, conflict, major pandemics, there is always a speedy, highly funded, and impactful coordination mechanisms. What are the major barriers not to have such strong coordination in times of routine development activities, and what can be done to bring the strong coordination? This is from your brother.
Great. Thank you very much. You always ask difficult questions, but and I think we can draw a lesson from the work I think you've done and so many other countries have done in the 2 cycles of the pandemic fund. When there's a crisis, we always come together. And in good times, we don't come together. So this is a little bit of human nature, But I think that is also a kind of disease we need to work on. How do we make sure that we stop the competition when the house is on fire, when you have a major outbreak? You should not be thinking about that silo approach. You should not be competing for funding. You should be working together. And that's why I said example of the pandemic fund was where we saw countries after countries coming together to secure the resources that are needed. At the same time, we also saw the quality of proposals, the better quality of proposals submitted. And I think the key message here is we need to do this all the time. It's not just during a major outbreak, but all the time we need to think about working as a team, and then that's the entire philosophy behind the One Health approach. Or you can, in the beginning, I called it, this is actually an integrated, interdisciplinary approaches. We have to come together, and this can be done. I think leadership is required, that somebody has to lead from at the country level to ensure that there is quality proposal, stop the competition, stop the siloing, because more and more people are suffering while we are competing each other to get the resources that are needed. In fact, sometimes we end up getting less resources when it comes to competition. But if we come together as a team, and also one fundamental issue is transparency and consultation. When we are developing this kind of projects, if we have a very consultative process at the national level, then we have a better outcome. Maybe what the professor talked about in terms of the value for money in the context of financing is, I think recently I really agree with the number one priority of any government is to take care of its people, and making health a priority, financing health, why health needs to be financed. And I think recently we had an excellent report from the Lancet in terms of global health by 2050. And the key message actually, or one of the key messages that came out of that report is why we need to prioritize, mobilize domestic resources. In many countries, they're more than enough in terms of resources, but they are put in the wrong priorities. So health is environment. Health for me is the single most important priority for any country, and that's why we need to prioritize in terms of our investment. Over to you, if there's another question. Yeah.
Thank you very much. There are two other questions.
Sure.
One is from Tasfaun. One Health approaches in pastoralist area. How we address One Health approach in pastoralists and semi-pastoralist communities in Ethiopia?
Excellent question. And in fact, we have a major Swiss-funded program actually on One Health in pastoralist communities in Ethiopia. I think that is a good opportunity to take advantage. I mean, brucellosis is a big issue within the pastoralist community. So I think we need to plug into this kind of existing initiatives that say around 20, either 15 or 20 million Swiss francs project that is actually happening in Ethiopia, but also partly the bordering nations, Kenya. So I think that you need to plug into that. It exists, and take advantage of that. If not, I'm more than happy also to send you some information on the initiative.
Thank you very much. Another question is from Devi. The One Health approach is just beginning to gain traction in most developing countries with its initial components. Could the introduction of the environmental component overburden the health system's structure?
Oh, quite the opposite. And then And first and foremost, you know, I know most people started talking about One Health approach as if this is something new. No, it's not. This is about an integrated response to a specific problem. So it's just a natural process. It's just that after the pandemic, you know, we started talking about we need a One Health approach in the context of, you know, that interface between human, animal, and the environment. This has always been there with us. But to answer the specific question on the adding burden to the health system, not really, because the whole idea is how do we prevent pandemic at source? If we manage to prevent it at the source, actually, we free up a lot of time, energy, resources for the health system. You will not be seeing people who are affected by the outbreak showing up in hospitals. And so, and I think the key message is how do we better invest in terms of prevention? You know, you guys are so good, the health sector. Prevention is better than cure. Absolutely. So why not invest in the prevention process in terms of a healthy environment? How do we make sure that we're not encroaching into wildlife? These are elements that needs to be included as a preventive mechanism. If we could prevent this from the source, then absolutely we will reduce the flow of sick people into our health facilities. So, but you know, invest in the environment, invest in a healthy environment, then you can significantly reduce the health impact. And then maybe one I saw is on something to do with leveraging technology. I think absolutely the right question. In particular, when we talk about building surveillance system, more specifically in the context of what we do in environmental monitoring, the information technology plays a huge role in aiding us to prevent, or at least to get, you know, a sense of what are the drivers of this pandemics if we have a better surveillance system put in place. Over to you.
Getnet, if I could comment on that.
Thank you very much. Now it's your turn. Thank you very much. Yeah.
Can I make an additional comment?
Sure. Yes.
So in terms of overtaxing the health system with the One Health agenda, if we were to build the kind of robust primary healthcare community platform that I'm talking about here, the surveillance function would just fit very nicely into the ordinary day-to-day work of these community health workers. The part-time workers would visit every home monthly. Each one would have 25 homes. And so there would not be a burden produced on the system by having a rigorous and robust surveillance system. It's just built into the system, and it would have a very powerful effect on detecting early outbreaks.
Absolutely.
Thank you. There is a question on community health workers. How can the community health workers be contextualized to the community they work with as urban and rural? And not only the payment is the problem in developing countries, but also capacity building programs and incentives to build their motivation in providing quality health service. How can the government give attention to this? Any probably best practices or something like that? Yeah.
Well, that's a terribly important question. And I think all of us know the struggles and the difficulties of making community health worker programs effective for all kinds of reasons. But one of the things that excites me about the model we're proposing is that it builds on a concept called care groups, in which many NGOs around the world have used this, but it's a process in which in our case, it would be the part-time community health worker would meet with its full-time community health worker who in a sense serves as a teacher and a trainer. But 10 of the part-time community workers would meet with the full-time worker on a monthly basis. And this would go on continually. Every month there'd be a meeting, and this group of part-time community health workers would learn each month something new about how to carry out their role and some new aspect of their role. And so in this continuous, which some people refer to as drip training, just a small amount of training on a monthly basis over time can build a very powerful capacity of the community health worker system to provide effective care. And by working in groups, by the part-time community health workers working in groups of 10, they help each other with their work as well. And so this would provide ongoing motivation and quality. And of course, the full-time community health worker would need to get ongoing training from higher up in the system. So we think that this model has great potential, and we don't go into the opportunities for career advancement in our model and our report and so forth, but I think everybody recognizes that we do need to have career advancement opportunities for people, and how those would be implemented would, of course, vary from place to place. The other issue is, of course, we've created a generic model that would need to be adapted to different situations, urban slums, rural pastoral areas. And so we're planning to do more work on this to modify the generic model to more specific contexts, but that's going to be further work on down the road.
Thank you very much. Probably there is another question around financing again. Irnagacho is asking both of you. I would like to ask that, what's your view on the financing ways that can be implemented to support PHC's role in achieving UHC, such as community health insurance schemes or public-private partnerships for developing countries like Ethiopia?
Well, I guess my comment on this is that there needs to be equity in health financing. And when I say that, I'm referring specifically to the fact that governments need to apportion money that is directed to specific geographic areas based on their population. The Lancet Commission on Financing Primary Health Care made this point, and it's a very important one, I think. So there needs to be a funding mechanism whereby a local area of 50 or 100,000 people can be assured that it's getting its fair share of resources to run its primary health care program. And that hasn't been the case so far. And it's just human nature that more resources tend to be invested in areas where they're least needed. And we need countervailing mechanisms to overcome this. And by assuring that each district, each sub-district has its adequate share of resources to fund primary health care is terribly important. Social insurance schemes are important, but we need to have a universal system so that everybody is covered within the system, whether they're employees or not. And a lot of these financing schemes tend to be targeted towards segments of the population rather than the entire population. And for social justice and for public health impact, we need to make sure that the system is adequately financed universally to reach everyone with a minimum basic set of services, which is what our model is calling for.
Thank you very much.
Yeah,
Maybe we can go to Mr. Wangas. Yeah, you can continue. Also, there is another question from Swaliha. which she's asking how about the role of One Health human aspects of UHC, PHC? How about the rest, like animals, livelihoods, and environment protection? Okay, please.
So I will come. Thank you very much. I will come to that last question, but just to flag on the previous two questions, one specifically in terms of community health workers, and I think this another work area that we do. We call it citizen science. How do we get the right information from communities? Communities are actually best positioned in terms of telling us the environmental change that we see. They are best positions in terms of to tell us, whether a movement of animals, behavioral change. So I think that investment in terms of community-based workers is so important. And then on the second one, on the public-private partnership element, I think I want to draw your attention to, one of the things our wonderful city, Addis Ababa, did was almost 10 years to the day is hosting the what is called the financing for development. It's called the Addis Ababa Action Agenda to implement the 2030 agenda, but that also includes SDG 3 on health. It was chaired by our good brother, Dr. Tedros. And one of the things in that, in terms of mobilizing domestic resources, in terms of mobilizing private resources, or international resources, and I think in the context of the private sector, we have to find a way to make them part and parcel of our health delivery system. I give you a good example in terms of, we're here in Europe, a growing number of, obesity, and this is about, the things we eat, the things we drink. The same applies in Ethiopia. Private sector should not just be making profit out of the health and well-being of our children, period. They need to be part of creating that healthy society, healthy environment. So I think they should be investing more in terms of primary health care, in particular, as I say, this is about prevention at the source. This is about addressing the root causes. So I think that there should be a platform for them, or to create a platform to make sure that private sector actually invest in the health and well-being of our kids or the entire society. And your last question is in terms of One Health and animals, or I'm sorry, I missed the full picture of that question.
Yes, animal health and livelihood.
So animal health is fundamental to the One Health approach. As I said, this is a pillar that looks at the human, animal, of course, plants and environment, and that I've also forgot. Plants it's also a key component of this, and that interaction is so fundamental. So we're also looking at, it's not only wildlife that today, you've seen cases where domestic pets also passing viruses to the owners. So it's important that we also taking care of the health of animals, but within the context of the One Health, what we have focused to a large extent is really on the negative impact. For example, aquaculture, how that is also contributing to the antimicrobial resistance. These are things that we have to look at, but it is also meant, a One Health approach is meant to protect also animals, not only just humans, but also a healthy animal is a component of that. Over to you.
Thank you very much. Thank you very much. Really, it was a wonderful discussion. Really, I'm privileged to to moderate this session. There are really very important points that are raised from the questions, also really from the presentations. As a way forward, we need to improve our health systems, continue to improve our health systems, including use of technologies, emerging technologies, innovations, improving our infrastructure, using reforms, medical supplies, vaccines, addressing MR, HRH, which is also a huge burden to developing countries, or LMIC, capacity issues, and others. And also we need to address inequalities like gender, geography, urban, rural, as you have said, economic, financial, stress, addressing vulnerable groups. We have to ensure sustainable health, financing, as you have presented and discussed, adequate financing, mostly, it should be sustainable, should be from the government. That's the stress, but we can start from our harness from our partnership. But in the end, I think the government should take responsibility, communities should take responsibility. We have to have financial risk protection. Also, it should be a sustainable program. We have to also center around primary health care and community health programs. As you rightly pointed out, really government as really the driving force. We have to look at policies, legislations that are supporting all these interventions. And then the other thing is our partnerships and collaborations, which are useful, and we have to maximize this, including community engagement. We have to engage them at all levels with our community health programs, because they are key players. Also the private and public-private partnership which was raised towards the end. So thank you very much. It was excellent presentation. Excellent presentations. I would like to thank the presenters and sharing their experience, rich experience, and the information they have that they gained through these years, and also participants, very active participants, raising key and specific questions, and also the organizers of this webinar. Thank you very much. Over to you, Tersit. Thank you.
Thank you, Prof. Ketnet. It was a wonderful moderation. Thank you, our guest panelists, and thank you all the participants for the active participation. A survey will be displayed at when I ended this webinar, so please fill that out to help us improve our upcoming events. Visit our website. Stay tuned for upcoming similar sessions. Thank you, everyone. Have a wonderful rest of your day. Bye.
Thank you. Thank you.
Thank you.